Welcome to our presentation on trauma-informed supervision. Maddie and I have a lot to share with you today. So for the first slide, some background. We just are going to give you the bare bones, which is we need to know a lot about trauma-informed supervision. We interviewed 9 supervisors who had formal training in trauma and supervision, and we analyzed them using CQR. If you have questions about any of that, we'll take those questions at the end. Maddie?
All right, so you're welcome to reference our slides after the presentation to kind of get some of that info if you're interested. But we'll start off by talking through some of the domains that came out of our findings from when we analyzed the interview. So I'm going to be talking about the supervisor's preparation and planning, the in-session behaviors, and the overall impact of the supervision session, which were just a few of the domains, but feel like the most information rich for our presentation today. So we got a variety of responses when asking about supervisor preparation activities and then also asking about their explicitly stated plans. And so we've put a few of the things that stood out from their responses on the slides here so you can reference those bullet points. But just to show you kind of the range of the ways that supervisors are getting ready for these sessions, they talked about reflecting on previous work with the supervisee, thinking about the client who was being presented on, maybe that was a high-risk client who the supervisor had kind of been involved with the case along the way. They had talked about maybe even watching or reviewing tape for the supervision session so that they had an idea of kind of what's going on. In terms of plans, the supervisors ranged in their responses from talking about going in, thinking about working with emotion regulation, either teaching that to the supervisee to use with the client or working with the supervisor or supervisee's regulation specifically. We talked about looking at skills or providing psychoeducation on trauma theory, ways to validate the client or the supervisee's experience, and as well as checking in with self-care. So there's a few different things on the minds of these supervisors before they got ready for these sessions. And so that's kind of where we're starting off.
And perhaps the most important thing to take from that slide, from my point of view, that Maddie just gave, is how intentional they were in their planning for working with these novice supervisees, which I think I forgot to say at the beginning. These are supervisors who were working with novices, which is not talked about in the literature hardly at all. The second domain was the supervisor's in-session behaviors. And the first category under those behaviors was observations of the supervisee's reactions, either to the client or to the client's trauma history or what was happening during the session. They were affective, physiological, and verbal. It was interesting to us that despite the fact that some of the sessions that they were recalling and describing to us an actual session with a novice counselor, they often remembered real details around the fears and the other kinds of emotions that their supervisees brought in, how activated they were, and could see that in their physiology, and the questions or the verbalizations that they would have around the client or their attempts at an intervention. So there was a range here also. The no visible effect refers to what Maddie and I will call an outlier, who of the 9, this was the only supervisee who did not have any kind of visible kind of response, and even their verbalizations were pretty straightforward, most of the time just saying, it was fun. Next slide, the second category under in-session behaviors were the supervisor's in-session decisions and actions. And this is once again a real statement of their intentionality as they were observing their supervisee and then making decisions based on what they were observing about what they needed to do in session. I'll give you 2 examples to give you kind of the range, because we found no subcategories here because they were so different. One supervisor went in ready to talk about the client's diagnosis because that's what the supervisee asked help with. And I think it was a DID diagnosis. But in talking with her supervisee, realized the client was talking about that diagnosis elsewhere and really wanted support around dealing with the trauma. And so she totally changed her approach to the supervisee and now was reminding her, asking questions, sort of walking her through, what do you remember from your trauma class? Actually, this is the only supervisee who had a trauma class, any trauma training. And then, so changing the course of direction around how to help and reframing that. And then there were two supervisees who got fairly dysregulated around when they were telling the supervisor the client's story. One supervisor decided that the supervisee really needed to tell the story because the client did not see it as trauma, and that was very perplexing to the counselor. The other one realized the counselor was just getting more and more dysregulated and stopped her from repeating the story of the client. So that gives you some idea of the real range of in-session behaviors and decisions, actions that were being made. The third category was under supervisors in-session behaviors, is we really wanted to highlight how much parallel process there was there, a good bit of deliberate modeling. Here's what I'm doing with you to help you get regulated. And then after that saying, and now those are the steps that you can use with your client. There was also some more traditional kinds of parallel process, interpersonal and intrapersonal dynamics. For instance, one supervisor became aware that some of her own dynamics, some of her own reactions, she was getting triggered by the client's story and was saying, oh, I've got to be aware and manage that. And outlier, if you will, was making statements. The observation was making statements around avoiding conflict, both with the supervisor, and he saw the same thing in the session with the client. So those are two of the different kinds of parallel process that we saw. The third domain was impact. And there were three categories under impact. The first was the impact of the supervision session on the supervisee. Both their in-session responses and the responses over time we asked about. And in general, for both, supervisees became more regulated. And you can see some of the things that supervisors were observing in support of that. They were very thankful for the feedback, the help, the validation, and a plan to move forward. And over time, most of them reported greater complexity and understanding as they talked about the client, what that trauma, the impact of the trauma on their lives, and were able to report client progress. The second category of impact was the impact on the supervisor. And here again, we see the wide range. The minimal was one supervisor who up front had planned to be very grounded and authentic because she knew this had been very difficult for the counselor. And so she maintained that and reported very little impact of the session on her. Moderate impact were supervisors who reported feeling very productive, proud of the supervisee, less worried and relieved about the client or the supervisee, or frustrated about the lack of potential, the lost opportunity of what the supervisee was capable for in the case of that outlier. Then there were two supervisors who reported very specific actions after the session, feeling like that they needed to, one talked about going back to his office and grounding himself, said he felt like he'd got splattered a little bit. Another, who worked in a setting with a lot of complex trauma, talked about rituals that he uses when he goes home, shower, listening to music, and talked about how those days were very draining when he had supervision and clients, that both he felt where he was expending a lot of energy to take care of them. And lastly, the last category under impact was impact on the relationship, and we didn't get very much here. Most of them had started with a very positive relationship. They talked about a session fairly far into the semester. Those About half did mention a positive impact, and the wording they used there was that they thought there was more trust and a closer connection because of the particular session that they described. Maddie?
So we'll shift from talking about findings into more of our discussion. In light of the findings, it seemed that across the interviews, there's evidence that both principles from trauma-specific counseling training were combined with principles from clinical supervision training. And so it may be that trauma-informed supervision is really an integration of training in both of those pieces. So to say a little bit more about those things, here's what we noticed in the interviews as we looked at them, that the supervisors, they were using their own background in the trauma counseling training, that the different models or options for conceptualizing trauma responses. And what they shared with their supervisees seemed congruent with the types of training that they had engaged in. And so other pieces for more general trauma counseling that seemed to make its way into the supervision session were emphasis on safety for the supervisee, working on trust within the relationship. Supervisors talked about making sure that for those supervisor or supervisees who had disclosed their choices and feeling a little bit more clear on kind of where to go next with their client. And so these supervisors not only use their trauma-informed framework, but they also combine that with their clinical supervision training and made use of things like the discrimination model, thinking about which role do I need to be in for the supervisee? Am I more in a teaching role, providing, information on a biopsychosocial model, or am I more in a counselor role to offer some support with the supervisee's regulation? We also saw an emphasis on attention to the developmental level of the supervisee, and supervisors kind of catering their interventions to those developmental levels so that the supervisee can really grasp kind of what the meat of the session is about.
And so some other ways that we identified where we saw an integration of these dual trainings, both formal training in trauma and formal training in clinical supervision, was for some decades, we've talked in the literature how to help clinicians learn to think like a supervisor. So if we think of trauma-informed supervision, what we saw kind of adapting that was that they were thinking like a supervisor who had trauma training, using both of those lenses kind of overlaid on each other. We also saw, since clinical supervision is really an educational process, we saw some signs of pedagogy that were used. The examples here are drawn from the science of learning principles, where they access supervisees' prior learning. What are the things that you know and how do those apply here in terms of basic counseling skills? Some reminders around that. For that one supervisee who had had a trauma class, what do you remember from that? How does that apply here? And another ask about life experiences, because they were working with both the client and the client's mother. And so what life must be like for this mother living with this child, and what are the ways that we can help the mother help the child. The structure and the scaffolding, which was developmentally appropriate, is also drawn out of science and learning principles. So that was one way we saw the integration. And then the next way, on the next slide, was that it reminded us a good bit of a study done, published in 2014 on expert supervisors. What I would just point out here in the interest of time is that those experts were very intentional, both in their planning and in the process of supervision, and also thinking about sessions afterwards. They used a cognitive map. They went in with an idea of what needs to happen here, and there were choice points where they made some decisions along the way, just like the supervisors in our study. Ongoing observations of the supervisee was also reflected in that study of expert supervisors, as well as monitoring, self-monitoring their own reactions to their supervisee, and in this case, also the client. So really thinking about their own emotion regulation and self-care. Maddie?
So another way that we thought of kind of framing the discussion for these interviews and what we found were to lay it out along the lines of Judith Herman's triphasic model of trauma therapy. And so for those of you unfamiliar with that model, it's a very basic, digestible framework for thinking about common factors in trauma counseling, essentially. So it's not theory specific. It has to do with kind of, if you're doing trauma work, no matter what theory you're using, you're likely following kind of these three phases. And so we're going to talk about the findings in that light so that supervisors interested in trauma-informed supervision can maybe have a framework to use informally to guide their work. So the very first phase of that is safety and stabilization. So that involves the groundwork in preparing the relationship to do some more vulnerable work. And with the next few slides, I'll walk through the phases, and then the bullet points highlight pieces from our interviews that might fit into these categories that we're creating for a framework. So the supervisors who might have been in this phase were working on grounding the supervisee. They were talking about integrating, how's the supervisee feeling about their work? How are they staying grounded? Things like that. And an emphasis on the safety within the relationship felt important. The second phase of the triphasic model, Herman calls trauma narrative or trauma memory processing. And so we've adapted this one and stretched a little bit to be more of kind of a cognitive processing piece. And so in this place, supervisors might be taking on more of a teacher role within that discrimination model and kind of giving some psychoeducation around trauma responses, how symptoms can look, some information on vicarious trauma and burnout, things that could be happening for the counselor as well. And so this is where the supervisor is kind of providing the information, also modeling how the supervisee might present that information to their client as well. So instead of working with trauma material, the supervisor is still very intentionally laying out a framework, and that kind of overlaps with what the trauma counselor might be doing. And the third phase is integration, which Herman calls reconnection. And so we've adapted this one a little bit to show that according to the triphasic model, this is the last phase of the trauma counseling where the client is integrating their new understanding, their new meaning of their experience into new pieces of their personality, and it influences their experience moving forward. And so supervisors can think of this phase as kind of ending the session and how do you prepare the supervisee to go forward and integrate what they've learned in the session with you, with their client. And so this could be making a plan for them to use with their clients. This could be some more teaching, some modeling, or even just some live role playing with the interventions that they're learning. And it can be fairly prescriptive. So perhaps the supervisor will say, you need to be assessing for safety every time you see this client, or I'd like you to issue this assessment and come back with me, and we can kind of take this new information and move forward with it. So here's a table that you can reference after our presentation to kind of just show you the way we're using some similarities of these phases as they're written and adjusting more in phase 2 to kind of stretch it to be maybe a different fit for supervisors versus trauma counselors. There's a few things that felt really important to highlight, including the parallel process, and then on the next slide, emotion regulation. So it seemed that supervisors were really aware of how they were modeling certain aspects of the session for their supervisee to then use with their client. And that felt really prominent and pretty obvious for most of them to pick up on how they're showing up with their supervisee gives a platform for them to know how to move through their next session with that client. And emotion regulation seemed really salient factor throughout. It seemed perhaps like a necessary component of trauma-informed supervision. Supervisors noted that they were kind of assessing for how the supervisee was presenting in their session, maybe how they're doing overall, and that the grounding, that safety and stabilization phase 1 had to happen before they could do some of the teaching and the cognitive processing pieces that go along with supervision. It also seemed that if the supervisor felt more regulated, or if they went in more regulated, it may be that supervisees can benefit from that with co-regulation and really benefit from the groundedness of the supervisor, and that can happen in the opposite direction as well. So if the supervisor goes into the session and is feeling very panicked or dysregulated, the supervisee might pick up on that and absorb a little bit of that as well.
These are some, as we move to limitations, these are some standard ones in qualitative research. I think we would add also, I would add that the session that they chose was perhaps not representative of all their work or of all trauma work. Only one of them really reported on a less than satisfactory or less than very positive, I should say, kind of experience. And the next slide. Implications, the triphasic model that Maddie has gone through would be one implication that could be particularly helpful for supervisors with not a lot of trauma training, and for new doctoral supervisors, having that structure could be helpful, kind of the cognitive map that experts are looking for or devising. Helping folks understand the planning and intentionality that's important to trauma-informed supervision, and all the activities that are happening in a supervisor's brain during a session. Lots of modeling, and so a conscious awareness of, as a supervisor, and particularly a trauma-informed supervisor in these sessions, particularly with novices, there's a tremendous amount of modeling going on. In terms of future research, yes, I think that kind of is the triphasic model again. So we'll go to future research, Maddie. The next slide. So in the implications here, sorry.
I don't have a future research slide.
Okay, go to the next one. Now go to the next one. And then here, implications. Okay, in terms of the implications here, everybody needs training in trauma. Our supervisors reported that they had no emphasis on trauma in their supervision training and no emphasis on supervision in their trauma training. And a lot of it, more attention needs to be given to emotion regulation, perhaps prior to students being on their work, as opposed to afterwards in helping them regulate. Next slide. So as Maddie said earlier, is this your slide, Maddie?
Yeah.
Okay, sorry.
Just to summarize, what we're advising or suggesting is that trauma-informed supervision really is an integration of formal training and experience in both of these modalities, so trauma counseling and clinical supervision, and that it's a combination of the two that can result in successful trauma-informed supervision.
In terms of implications for supervision research, which I jumped ahead to a while ago, a lot of additional studies of in-session events, both in counseling and supervision, is an issue that folks are talking about these days. One that comes to mind for us in terms of a follow-up to our study is looking at specific types of trauma. For instance, none of the supervisors in our study, which was pretty diverse, none of them talked about racial trauma, which we think could probably show some very different kinds of information, decision-making, and observations in the session. And then maybe looking at how supervisors are using different interventions, such as actually using the counseling session recordings with their novices. In addition, next slide. Longitudinal. Some of our supervisors were in settings where trauma was pretty frequently a topic of a presenting concern of clients. So they gave them some preparation up front and helped their supervisees think ahead to what this would be like, and gave them some training and modeling and hints up front. So longitudinal investigations of what that's like across a semester or perhaps even a whole internship-based year. Certainly tying these actions and decisions of supervisors to outcomes is a common recommendation in supervision research these days. Replication with supervisees that have more trauma training and more clinical experience would also be helpful as a comparison and contrast. We saw a lot of work that was really specific to novices in our study, since and really reflected those developmental models, and what would that look like with more advanced supervisees, especially with trauma experience. So that's our bare bones of presentation today on our topic, and we now open it up for questions.